Hello, my name is Dr. Diwan S. Raja. Today I will discuss about the anatomy of the scalp. What is scalp? Scalp is the skin and subcutaneous tissue over the neurocranium, or you can say scalp. We can say scalp as a soft tissue over the vault of the skull. Okay, soft tissue over the vault of the skull. Okay, so we got scalp. Scalp is the skin and subcutaneous tissue over the neurocranium, or you can say soft tissue over the vault of the skull. So if this is our skull, so the skin and subcutaneous tissue over the vault of the skull, or this is the neurocranium, this part is called neurocranium. The skin and subcutaneous tissue over the neurocranium is called scalp. Okay, so we got the definition of the scalp. Now we learn the layers of the scalp. Before going to layers, we must know extension of the scalp. Extension of the scalp. Okay, it extends from anteriorly from the supraorbital margin. Posteriorly, it extends to the external occipital protuberance and the superior nuchal line. Laterally, by means of temporal fascia, it is connected to the zygomatic arch. So, we got the extension anteriorly supraorbital, anteriorly supraorbital rays, orbital rays. Okay. Posteriorly, it is attached to the external occipital protuberance and superior nuchal line. Okay, we got the extension anteriorly supraorbital rays, posteriorly it is attached to the external occipital protuberance and the superior nuchal line. Laterally, if we go to the laterally, it is attached to the zygomatic arch, via the temporal fascia. Okay, we got the anterior extension. It is extension anteriorly, posteriorly, laterally. Okay, we got the scalp definition, layers of the. We got the extension of the scalp. We'll go to the layers of the scalp. Okay, so we always remembered rule of 5. So we'll remember rule of 5, and we'll also spell the scalp as C-A-L-P. Then we'll get the layers of the scalp. So S means skin. Here we got the skin. C, this is skin. Then connective tissue. Then we got aponeurosis. Then we got loose areolar tissue. Then we got the pericranium. So these 5 layers are the layers of the scalp. So again, skin, connective tissue, aponeurosis, loose areolar tissue, and the pericranium. Skin of the scalp, like other part of the body, skin is composed of epidermis, dermis. The skin is rich in hair follicles and hair. So we have numerous hair. Okay, hair follicle. We have also sweat gland, sebaceous gland, okay, sebaceous gland, sweat gland, hair follicle, and numerous hair. We call it scalp hair. Scalp hair. Okay, we got that. Skin. Then we get the connective tissue, the second layer. The connective tissue. Second layer is the connective tissue. Okay. Connective tissue, another structure. It is composed of collagen fibers mostly. Okay. And it is very vascular. Very much vascular. A lot of the connective tissue fiber, okay, is present in the connective tissue layer. Then we get the aponeurosis. It is called epicranial aponeurosis. Also called Galea aponeurotica. Okay. Galea means something like shield. So something like shield here. So it is called Galea, like shield. Okay. Galea aponeurotica or epicranial aponeurosis. Okay. So we got that. This is the third layer. Okay. Then we go to the fourth layer. Fourth layer is the loose areolar tissue. Areolar tissue. Okay. It has many potential spaces, vascular, and it is very important layer. Okay, loose areolar tissue, a lot of clinical importances. And they also have emissary veins. Emissary veins are the veins which connects the loose areolar tissue to the dural venous sinuses inside the cranium. So suppose if you have parietal emissary vein, it will connect the loose areolar tissue of the skull to the superior sagittal sinus. If you have here the mastoid emissary vein that will connect the loose areolar tissue to the sigmoid sinus, the venous sinus, sigmoid venous sinus. Okay, so loose areolar tissue is very important. This is called danger layer of the scalp. Danger layer of the scalp. Why it is called danger layer? Because infection from the scalp may go through the emissary vein, through the skull bone, enters into the intercranial dural venous sinuses. So infection from external to the cranium, to the skull bone, may go to the internal to the cranial cavity through the emissary vein. Okay, so that connects the loose areolar tissue to the intercranial structure. So the brain may be infected, or there may be infection going to the dural venous sinuses. Okay, this is the loose areolar tissue. Then we'll go to the pericranium. Okay, pericranium. Okay, there is the fifth layer, the pericranium. Pericranium. Okay, this is the periosteum over the skull bone. So we have skull bone, it is covered by the periosteum. We know periosteum is the fibrocellular. This is the skull bone, so it is covered by the periosteum, and we know that periosteum is the fibrocellular connective tissue over the bone. So the pericranium, we can call it, this is the periosteum over the skull bones. Okay, so it can be separate out from the skull bone, but it is fixed to the joint between the skull bone. We call it sutures. Okay, so the pericranium are attached very much tightly to the sutural line of the skull bone. Okay, they are attached tightly to the sutures of the skull. Okay, we got the pericranium. So we got the rule of 5. We can spell scalp as CALP. We have 5 alphabet there. We have 5 layers of the skull that covers the neurocranium or vault of the skull. Okay, so the skin and the subcutaneous tissue that cover the skull bone is called the scalp. We know the extension. Okay, we have gone through that part. Now we go to the blood supply, arterial supply of the scalp. Okay, arterial supply, again, rule of 5, 5 artery on each half. So 5 arteries on each side. Okay, so if you draw a line here, then you will get 5 artery on this side. This is the vault of the skull. This is the nose. This is the occiput area. Excuse me. So we'll get 5 artery here, 5 artery here. What are the arteries? We have the supratrochlear artery, we have supraorbital artery, These are branches of the internal carotid artery. We have the superficial temporal artery. Okay. The superficial temporal artery is one of the terminal branches of the external carotid artery. We know that the external carotid artery has two terminal branches. One is the superficial temporal artery, another one is the maxillary artery. The superficial temporal artery is this. So this is one supratrochlear, supraorbital, superficial temporal artery. Then we'll get the posterior auricular artery, posterior auricular artery, posterior auricular artery. That is a branch of the external carotid artery. We'll get the occipital artery, occipital artery. There is a branch of the external carotid artery. So, supratrochlear artery, supraorbital artery, branches of the internal carotid artery, superficial temporal artery, posterior auricular artery, occipital artery, branches of the external carotid artery. So, this is the superficial temporal artery. This is the posterior auricular artery, number 4. Number 5 is the occipital artery. So, rule of 5 for each half. This half, again we get these arteries on this side. Okay. So, we got the 5 arteries on each side. Each half of the skull will get 5 arteries. 5 arteries on this side. Same arteries on the other side. Okay. So, we got the blood supply, arterial supply. How about the venous drainage? Okay, 5 veins on each side, like the artery, the corresponding veins. Okay, we get the veins, supratrochlear, supraorbital vein. Okay, we have the supraorbital vein, supratrochlear vein. They would go to the angle of the eye to form the angular vein. Okay, superficial temporal vein, tributary of the maxillary vein. Okay, posterior auricular vein will unite with the posterior division of the retromandibular vein to form the external jugular vein. Okay, and occipital vein, well, it may end up in the suboccipital venous plexus, and it may enter into the internal jugular vein. Okay, we got the veins. So, rule of 5, venous drainage for a half, 5 veins. Okay, now we'll go to the nerves. Okay, we'll go to the nerve. 5 nerves for each quadrant. Okay, we divide into 5 here. This quadrant 5, this quadrant 5, this should contain 5. I have shown the nerve on this side. Okay, let's start one by one. What are the nerves? We have the supratrochlear and supraorbital nerve here, supraorbital nerve here, supratrochlear nerve, then supraorbital nerve here. Then we'll get supratrochlear, supraorbital nerve. Then we get the zygomaticotemporal nerve. This is one nerve. 2. This is the zygomaticotemporal nerve. Zygomaticotemporal nerve. Okay, we got that. Then we'll get the auriculotemporal nerve, number 4. Auriculotemporal nerve. So we got the rule of 5. So we need one more. These all are sensory. They are sensory. We have one motor nerve, the number 5, that is the temporal branch of facial nerve. Facial nerve is the 7th cranial nerve. This is motor. So we have 4 sensory and 1 motor nerve. Suppose this is supratropial, supraorbital, zygomaticotemporal nerve. These are coming from V1. That means ophthalmic division of trigeminal nerve. Zygomaticotemporal nerve is coming from V2. Then auriculotemporal nerve is coming from V3. V3 means mandibular nerve. V2 means maxillary nerve. V1 means these two ophthalmic nerve. These are the division of the trigeminal nerve. Okay, we got that. Motor nerve, temporal branch of the facial nerve, innervates. It is motor, so it should innervate a muscle. What is that muscle? It innervates the frontal head of the occipitofrontalis muscle. It also innervates the auricularis anterior, auricularis superior muscle. Okay, so many muscles, but this supplies particular temporal branch, innervates the frontal belly of the occipitofrontalis muscle, auricularis superior, auricularis anterior muscle. So we got 4 sensory nerve for pain, touch, temperature, sensation, and this is for the muscle action, the temporal branch of the facial nerve. Okay, so this is for this quadrant. Like this, we'll get this 5 also here. Then how about posterior quadrant? Okay, so here we'll get different name nerves. Okay, we'll get 4 cutaneous nerve, the sensory nerve, and 1 motor nerve. Okay, let's start one by one. We'll get the great auricular nerve. Okay, great auricular nerve. What is the root value? C2, C3. Okay, get auricular nerve. Then we get this actually pick up sensation, just small part posterior to the ear, only small part. Okay, that maybe this part. Okay, great auricular nerve, C2, C3. Okay, so we got that. Now we go to the greater occipital nerve. Then we get the lesser occipital nerve. Okay, what is the root value of the greater occipital nerve? C2. Okay, this is coming from the cervical plexus. Greater occipital nerve is the branch of the posterior rami of the C2 spinal nerve. Lesser occipital nerve is coming from the cervical plexus here from the C2. Okay, then we get the third occipital nerve. Okay, third occipital nerve is the branch of the posterior rami of the C3 spinal nerve. Okay, so you got all sensory for this quadrant, like this quadrant. Okay, but we need one motor, that is the posterior auricular branch of the posterior auricular branch of facial nerve. Okay, so these are sensory again for this quadrant, that quadrant. Sensory. This is motor. If it is motor, then what muscle is innervated by this branch of facial nerve? It innervates the occipital head of the occipitofrontalis as well as the auricularis posterior and auricularis superior muscle. Okay, so this innervates the occipital head of the occipitofrontalis, occipital head of the occipitofrontalis muscle, and auricularis superior and auricularis posterior muscle. So we got the nerve supply. Now we'll go to the lymphatic drainage. So again, we have gone through rule of 5. Do not forget the rule of 5 for this 5 nerve, 4 cutaneous, 1 is motor, 4 cutaneous, 1 motor. So almost 20 nerve will get together. We'll get 10 artery, 10 veins, and 20 nerves. Okay, so great auricular nerve, greater occipital nerve, left occipital nerve, third occipital nerve, posterior auricular branch of the facial nerve for the posterior quadrants, each quadrant, this and that. Okay, so again, rule of 5, 1, 2, 3, 4, 5. Okay, we got that. The rule of 5. Okay, now we got the. Now we may not learn the rule of 5 now because we are going to the lymphatic drainage that doesn't follow the rule of 9. Lymphatic drainage. Okay, lymphatic drainage. Suppose if I draw a person like that. Okay, lymphatic drainage, his ear is here. Okay, this is ear. So we'll get, this is the person. Okay, so lymphatic drainage, post auricular region. Here we'll get the post auricular region, that is behind the auricle of the external ear. We'll get the occipital lymph nodes. Occipital lymph nodes. We'll get mastoid lymph nodes. Mastoid lymph nodes. Okay, how about preauricular, in front of the ear? Okay, preauricular region will get preauricular lymph node just in front of the ear. Preauricular lymph node, ocular lymph node. Okay, and we get the parotid lymph node, parotid lymph node. Okay, so where this lymph node will go, this is preauricular, this is postauricular, they will go to the deep cervical lymph node, deep cervical lymph nodes. Ultimately they will go there. So you got the lymphatic drainage in front of the ear, preauricular, parotid. Posterior to the ear we have the occipital and mastoid. Where they end up? They'll end up in the deep cervical lymph node. Okay, we got that. Now we'll go through some of the clinical notes or applied anatomy. Okay, so let's go to the applied anatomy. Okay, applied anatomy. Or we can call it clinical anatomy. Okay, very good. Okay, number one, our skin, our scalp is vascular. So any injury to the scalp will cause profuse hemorrhage because we have a lot of blood supply and they have free anastomosis. Okay, and when there is any damage or cut in the scalp, bleeding come out from two sides of the artery because they have a lot of anastomosis. That's the reason for that. And also, okay, vascular artery does not retract. Artery does not retract. So there will be more chance of bleeding. Okay, we got that. Scalp is very vascular, and we have three layers here. Okay, we have three layers here. 1, 2, 3 layers. They together, skin, connective tissue. Okay, skin, connective tissue, and the galea aponeurotica or precranial aponeurosis, neurosis. They are together, we call them as scalp proper, also called surgical layer of the scalp. Idea is that in case of craniotomy surgery, these three are taken together, and it also contains a part of the superficial temporal artery in craniotomy. So this is also called surgical scalp or scalp proper. Okay, we got that. And our skin is a site for sebaceous cyst. Sebaceous cyst because we have a lot of sebaceous gland. Okay, we got that. Then this is very important, the galea aponeurotica or epicranial aponeurosis. Galea aponeurotica, aponeurotica. It is like a shield. It is connected to two muscles. One is the frontalis, another one is the occipital head. Okay, this is frontalis. This is occipitalis. Okay, occipitalis is connected to the external occipital protuberance in the superior nuchal line. Frontalis that has no bony attachment. It is attached to the skin and subcutaneous tissue over the eye. Okay, so frontalis. So it has no bony attachment. So this is the aponeurotica, aponeurosis. Galea aponeurosis. Okay, aponeurosis. Okay, epicranial aponeurosis. Okay, we got the aponeurosis, epicranial aponeurosis. So this is important. Idea is that we get this aponeurosis is connected to the temporal fascia and attached to the zygomatic arch. Okay, fascia. Then go to the zygomatic arch. Matic arch. Okay, on each side. Okay, we got that. Frontalis can move, occipitalis can move. Okay, we may wrinkle our forehead. There is a test of the seventh cranial nerve or facial nerve. If you can wrinkle properly, if you can wrinkle, then it is maybe associated with that of Bell's palsy or lower motor neuron lesion of the facial nerve. If we cannot wrinkle our forehead, then it is the Bell's palsy or the lower motor neuron lesion. In case of upper motor neuron lesion of the facial nerve, usually the forehead area is not affected. Okay, then we can wrinkle the forehead. Okay, so we got the frontalis callioponeurotica. So if it is a connective tissue, so if it is cut or lacerated, then there will be a big gap here. So if it is cut, then the skull makes a big gap if it is cut. Okay, the aponeurosis, it will be separated by the muscle, so a huge gap. So repair of the scalp injury may need time to stitch together. Okay, that is the importance of the Gallia aponeurotica. Due to its presence, it may gap, meaning injury or damage to that. Okay, very good, we got that. Now we discuss the loose areolar tissue. Loose areolar tissue, what is its importance? So infection from there may go inside the skull bone. Suppose here is the loose areolar tissue, so it will penetrate the skull bone, will go to the brain. Okay, so this is the emissary vein. Okay, emissary vein will go through the outer table of the skull bone, the diplo layer of the skull bone, inner table of skull bone, go to the brain, may go to the intercranial dural venous sinuses. Infection may go in that direction. Okay, this is one clinical importance. Another clinical importance, any injury to the forehead or head injury. So blood will go anteriorly and blood will go around the eye. Okay, around the eyelid will get ecchymosis. Okay, ecchymosis because the frontalis muscle is inserted to the skin and subcutaneous tissue. So any injury to the skull, any head injury, there may be chance of getting black eye, or you may call it raccoon eye. Okay, maybe panda eye, black eye, due to the extravasation of blood from this layer. Okay, underneath the aponeurosis, going anteriorly to the eye, around the eye, go to the upper eyelid, lower eyelid, make this black color. We call it black eye or raccoon eye, or you can call it panda eye. Okay, we got that. So there is the importance of loose areolar tissue. And the important point is that the superficial temporal artery, okay, superficial temporal artery may undergo giant cell arteritis, a vascular disease of the elderly population. Not only one artery is affected, also intercranial artery affected. There may be chance of arteritis in the branches of the ophthalmic artery that may lead to blindness. So physician take a part of the temporal artery for biopsy. Okay, physician take a sample of this artery to find out the giant cell in the wall of the artery by biopsy. to diagnose the giant cell arteritis. Okay, we call it giant cell arteritis. Okay, so this is the artery to take biopsy to diagnose giant cell arteritis. That is the devastating condition, may lead to blindness because we may have also intracranial involvement. Okay, so we have covered everything as far as I know about the scalp. So please support my channel, please subscribe me and hit the button, and please share the information with your friends, and please ask me any question. I'll be very happy to answer the questions. Have a nice day. Bye now. Bye. Thank you.